recording and people might trickle in a little bit. Let's see. Okay, here we are. Official welcome. Really glad that we can do this. Really glad we can gather. I'm really glad to take advantage of my access to midwife friends. When I lived in Berkeley, what's that? When I lived in Berkeley, one of my housemates was a nurse midwifery student. And so there was a crew of people who would come over and study every now and then, as well as just like a crew of people who would hang out with each other, and they all developed this really cool bond with each other. And I got to see them and get to know them a little bit. And Cara was a part of that cohort during those years. So I got to kind of witness them go all the way through the NP part of their program. And Cara, y'all graduated in spring 2 years ago? 3 years ago? 2 years ago.
Fall?
Oh, fall, that makes more sense.
Almost 3.5 years ago.
No, wow.
Fall
Cool.
2017.
Okay, cool. And so I don't have a super strong sense of what Cara's been doing since she graduated. Very excited to learn about it. And what I do know is that Cara is in Boston, and she is both working as a nurse midwife and also as an educator. And just super grateful and honored that you're here today to hang out with us a little bit. Structure is going to be very loose. So when you've got questions, please go ahead and feel free to ask. Welcome, Cara.
Thank you all so much for having me here. This is like one of the virtues of the last year, is that connecting and creating community has taken on a whole new form. So I'm grateful for that. I have a sleeping dog in the background who might stir and bark if anyone comes by, or just snore lightly. So I apologize in advance.
Cara, could you give us a quick sense of, like, I don't know, what got you into nurse midwifery, and like, I mean, just anything you feel like is worth sharing with us a little bit.
Yeah. So I can tell you a little bit kind of like how I got here and maybe what my job looks like now. I went into nursing as a second degree, really specifically with the aim of going into midwifery. In my previous career, I worked as an anthropologist and had always known that I wanted to do something regarding health, specifically reproductive health. Short answer is my mom is a midwife, but I think for many years I kind of ran away from that idea and was looking, because it was my mom's career. And in my work as an anthropologist, really came across a whole collection of women who didn't have a lot of access or agency in the healthcare decisions that were made for them, about them, or just full understanding. And in my mind, I was like, all right, this is what I want to do. I want to become an advocate. I want to be somebody who hears people's stories and helps make their healthcare experience one that is driven by the patient, by the consumer. And I think because I had this model of my mom in mind, I was like, of course, that means advocate means midwife. And so I went back to nursing school. I went back to nursing school in Philly and did a program that was 1.5 years, and really thought like I was going through the nursing component just to get to the midwifery component. But then I stopped and I worked as a nurse for 1.5 years in Philly and on a labor and delivery floor. And I fell in love with the role of the one-on-one nursing. I think like when you think about advocate and when you think about somebody who really gets the most intimate view of a patient's experience when they're in the hospital, it is like hands down the nursing staff. And really got this ability to be with women, with families, with pregnant and laboring people in a like one-on-one prolonged experience, actually more than I probably do now as a midwife, because the role of the nurse was really at the bedside. And from there transitioned and left Philadelphia and went to California for graduate school, and kept working as a nurse throughout my midwifery program. I worked at Kaiser in California and continued to do labor and delivery work, and it was wonderful. I was like learning this new skill of midwifery where I felt fumbling and unsure, but then had this career of nursing to kind of help me keep my feet grounded. And so yeah, so that is the journey through and up to school. And then here I am now in Boston. I am a midwife. I practice at Boston Medical Center, which is Massachusetts. It's two things. It's the affiliate hospital for Boston University. So Boston University Medical School sends their learners to Boston Medical Center. And BMC, or former Boston City Hospital, is also the largest safety net hospital in the state of Massachusetts. So the population that we see is this really kind of across the spectrum people from all different walks of life, where a lot of folks who are affiliated with the university who are learners, but then also people who really benefit from the systems and the safety net systems and structures that the hospital has set up. So that's everything from like the hospital has a specific department and clinic geared towards refugees and people who have recently arrived to the United States. And so we see lots of people who are refugees and who get like legal and social aid in addition to birth care. BMC also has a like pretty big, one of the biggest substance use clinics in the Northeast. So we get people from all over New England who come to Boston Medical Center for treatment for addiction history and birth care. Specifically my role, is it okay if I keep going? I'm on a roll.
Yeah, I'm soaking this up.
Specifically, my role is that I work. We also have one of the biggest midwifery practices in the city. So we are a practice of about 20 staff midwife with then a few extra kind of part-time midwives on the side. And I see patients in the prenatal period. So I see patients in the clinic 2 days a week. One full day is run-of-the-mill prenatal, right? So everybody from like their first trimester to second, third, up till they give birth. And I really see the same patients over and over again throughout most of their whole pregnancy, which is pretty amazing. 1 day a week, I go out on a mobile clinic. So we have started a mobile clinic in the time of COVID to help bring care to people's doorsteps. It was started based on a pediatric model of bringing vaccines to people's doorsteps so that kids could get vaccinated when the hospitals closed down or became more restricted in COVID. And so now 1 day a week, I see moms and babies together on an ambulance, which is kind of wild. We go out with a pediatric nurse practitioner and do like a joint care session for new moms and babies. And then 1 day a week or one afternoon a week, I also see patients in a new clinic that I started that's all about sexual wellness. So patients specifically who come in with complaints of sexual pain or pleasure, I work with a doctor. And so it's a much more like, and we see these specifically this patient population. So that's like the biggest gynecology aspect of my care is that I get to see, so I see lots of prenatal and postpartum. And then one afternoon a week, I see lots of GYN complaints or GYN concerns regarding sex and intimacy. Scattered in there, I also work on the labor floor. I teach in the medical school, and I have nurse practitioner students who are with me in clinic. And I work like a scattering of like an overnight here or a 12-hour shift tomorrow and yesterday, so it's, my schedule has some sense of regularity to it, but then a lot of flexibility and surprise that I knew I was getting into this job.
I know Isaiah had a question. Isaiah, did you want to jump in?
Yeah, can you hear me well?
We got you.
Hello. My question was in regards to translating the knowledge you have, you get in school into practice. Do you mind sharing, like, what's easy and what's hard, as far as, like, translating whatever you learn in school into actual practice?
Yeah, I think that's a great question. I think the things that I thought were going to be harder were actually easier, right? Like hand skills. I think that in school, I was super worried about things like placing IVs and learning how to check people's cervixes and learning how to get through all of like the things that you focus on in a simulation of nursing school. And I think that actually felt really easy to master. Like a lot of the hand skills, by the time I was done nursing school, I felt like comfortable in assessing people's vitals and placing IVs and understanding a lot of like the tactile stuff of nursing. I think one of the things that's the most challenging and I continue to work with, but it's also the most rewarding, is creating a space for people to talk, right? Creating a space for people to share and to be vulnerable in many different settings. And that continues to evolve, right? Like I figured out how to create a space for people to be vulnerable during their birth. But then COVID happens, and how do you create a space for people to be vulnerable via Zoom or in a birth where they can't have a specific amount of, their support people there? So I think it's one of the things that drove me in is kind of safer spaces or vulnerable spaces for people. And it continues to be challenging because the world continues to change around you.
I know right after you graduated, you were working as an RN for a little while in San Francisco. And during that time, the nurses union went on strike, right? And I'm just wondering, like, what it's like being a nurse. Like, we're learning how to be a nurse and stuff, but like you're also learning how to be like a citizen in this population of people, and what that experience has been like.
Yeah, that's a great question. I mean, I was fortunate enough to be in California, which has the California Nurses Association, is one of the biggest in the country and has really done a lot of the groundwork to like set staffing ratios and break times and a lot of these things that I didn't even think about were part of the job. And so I think it's all about surrounding yourselves in the right environment and finding those systems. But yeah, I think that's it is a continuous learning curve where thankfully you don't have to learn it all on your own, right? Like I don't have to learn how to be a nursing citizen on my own. I just have to be constantly willing to find and join who's working to make the workplace a better spot. Or I think a lot about it like, there's so much work to do in terms of equity and inclusion and anti-racist work within healthcare. And a lot of that has to do with, recognizing that it's not my job to single-handedly fix it, but that to stay curious and to stay open and to find the people who are doing the work, because there's so much work being done out there. And there's so much of the job that continues when your work shift ends. So, I mean, I don't know if that answers the question, but like really staying curious to what other people in the field are doing, and recognizing that one of the amazing things about this job is that you are signing up for more than just being a nurse from 7A to 7P, but you can't help but commit yourself to a certain lifestyle and a certain passion for kind of improving the workplace and the world that you live in.
How is that transferred over into working in Boston? Is it similar or is it different?
From California?
Yeah, I mean, are the Boston folks unionized? And
yeah.
like, yeah, how are y'all working together?
So as a midwife, I am not unionized in Boston. The nurses are unionized. It It's hard to know. I think in California, there's so much that I learned about the benefit of the union. Like you could never go into a conversation without whenever you had a conversation with your boss, with your superior, you always had the option of having a union rep there. Like you could always have somebody who was there and who was supporting you. And there was lots of activism and demonstration in terms of improving nursing rights in California. I don't feel that as strong here. And part of that could be my naivete because I am not part of the union as a nurse midwife now. But it was a pretty radical learning experience for me in California to really learn like, wow, I am not coming only to this job with my peers and as myself, but I have this whole force of the union that is there. That really organizes around kind of any injustice or any need for change in the nursing population. And I wish there were a little bit more present here. I see some tough days right now between my nursing peers and their management. And the nurses are in a union, but it's not the same power as the California union. And I think that there could be some more, I don't want to say workers' rights, but I think that there could be somebody else supporting the nurses if the union were more involved where I was.
Going one step deeper, and like I said earlier, if anybody feels curious about anything, please jump in. One step deeper into equity questions. This is a question from Brittany, who wasn't able to make it. She said she's particularly interested in racial issues in healthcare. And specifically this study that's come out in the last year where, and I'm not positive that this is the right data, but where Black maternal mortality is 2 to 3 times higher than that of white women, and that they're more risk. I know that it was something like higher mortality for babies with white pediatricians or white people delivering them compared to people of their same race. But I don't remember if it was mothers as well. But like, okay, bigger picture. She said she's currently reading the book Killing the Black Body by Dorothy Roberts, which addresses a lot of systemic issues. And like, we're just like wondering what your experience is like in this, both as an educator and as a nurse practitioner within a system that is historically just really messed up.
Yeah, I think the statistics are on point. It's 2 to 3 times higher for maternal morbidity and mortality. But if you go to certain areas of New York City, it's up as high as 8, I think, or 6 to 8 times higher. And there is a discordance, right? We know that in general, people, Black people who are cared for by Black providers have better health outcomes. And we see it among babies, that some of the data has shown it among babies as well. And it is so you asking, I don't remember what your question was. How does that play out?
I mean, like, we're sort of in this scholastic perspective where we can kind of look at it and be like, wow, there's some major problems there. And I think in some ways we have a bit of luxury to be able to be zoomed, or at least I feel like I have that, being able to zoom out and look at things from the outside. And I'm just wondering, like, how is your day-to-day experience of this, and like, what are you able to witness or accomplish, like in your own lived experience?
Yeah. I mean, I think first of all, there's so much work to do. There's so much work to do on this. And this feels like the call of my career, right? Like, this feels like one of the reasons that I show up to work and do what I do every day. And it's also one of the reasons why I am where I am. I think we serve a patient population that is probably less than 40% white, but meaning from all over the country, all over the world, and a large percentage of Black individuals. And BMC has made a commitment to making the providers reflect that. And so we have an incredibly diverse collection of both midwives and doctors, and we're still working on it, right? We still struggle. I think like it affects so many different levels of care. I think the big thing that I've realized in my career is that like patients know this, right? Like patients know, Black women know that they're at a higher risk when they come into the hospital to give birth. And so one of the cornerstones of my practice this past year has been to talk about it and to incorporate it and to address those fears, and to help people find, you know, as much as possible, find the safety that they need within the halls of the hospital. And then in our practice to get as creative as possible as to how we can do things to reduce those inequities. And so, you know, every institution is doing different things. Every community will do different things. There's a few things that we're doing right now that at BMC, and I can kind of talk about the nitty gritty of that. Like one of them is offering centering, right? Have you guys heard about centering pregnancy? It's a model of group prenatal care where instead of like one-on-one traditional prenatal care where I sit and talk with a patient one-on-one for 20 minutes, centering pregnancy is a group of about 10 to 12 moms or 10 to 12 pregnant people who are all due around the same time. And they have a 2-hour session together with a midwife who helps facilitate. And so it's a group model of care. There's been a lot of data looking at group care specifically for things like diabetes, like cardiovascular disease, and how much education sharing and benefit it brings to clients. And so centering pregnancy has been shown to decrease low birth weight babies and preterm birth, specifically in Black women. And so like things like alternative models of care, right? Systemic interventions that we can do to help address these inequities. Or there's things like a prenatal, have you guys talked about prenatal aspirin in school? No, giving prenatal aspirin in pregnancy, right? So there's projects around prenatal aspirin.
Anna remembers it, but I don't remember it.
Does anyone know what it is? Do you know what you can do?
Is it just for the platelet qualities of it?
No, it's supposed to reduce the risk of preeclampsia for people who are at risk, right? And so it's a whole list category of like who we know has a higher risk of preeclampsia statistically, right? So like first-time pregnant people, people who are over the age of 35, people who have a BMI above a certain level when they start pregnancy, kind of this whole slew of things. And one of our criteria at BMC is being Black, right? And so like, what is that actually, right? Like, it's not about being Black as some risk factor for poor pregnancy outcome, it's about racism. And so like, this is like the kind of thing that I talk about with patients is like, how do we know that racism can affect your care? And what are the resources that we can do to connect you to that? So like, that's on the very kind of patient side of things.
One quick question, do you get to participate directly in centering pregnancy groups? Do you get to facilitate them?
I don't, just because it's not in my prenatal care schedule, but we do have like, I say about half of our midwives do centering as opposed to one-on-one.
And is that like just a midwife thing? Like, are there other people that get involved who, I don't know, it just sounds really cool. And it sounds like a part of healthcare that would be amazing to be involved in on some level.
Yeah. No, so centering pregnancy, so no, it's doctors do it, right? It's been so effective at improving birth outcomes now that physicians now lead centering pregnancy groups. And so we have a few physicians who, I think they stopped in the beginning of COVID, and it's been the midwives who have first picked it up via Zoom. But yeah, physicians who lead centering pregnancy groups. It's also amazing because at the end of seeing like 20 patients in a day, I'm exhausted when I'm talking to everybody about like natural methods of cervical ripening and like, you know, breastfeeding support. So if you can do it like once as opposed to with 20 people, it's so much more enjoyable for everybody.
I've heard that. Yeah, that it's like a rejuvenating experience.
Yeah.
Well, when you talk about it, it almost seems like so obvious as to why haven't we been doing this from the beginning? Because part of the problem with any medical condition, pregnancy or not, are the fears that naturally come with it. So you're giving education, but you're also providing like a support and therapy group at the same time.
Yeah.
You know, just for people to share their experiences and what they're feeling and going through. So you feel like you're not alone, and some, you know, some of your problems or have been experienced by others. It sounds really awesome.
And it breaks down the hierarchy of healthcare, right? Like so much of information is not actually like receiving the information, but it's about how you feel about it, right? So you can receive that in community where other peers are sharing the information, and not just some provider who's supposed to occupy some like higher level in a hierarchy, but instead everybody sits in a semicircle and, you know, knowledge is shared by all.
I want to see like centering diabetes.
Yeah.
Like,
Yeah.
because like I think of diet and exercise being this thing that practitioners can say like, here's what I'm prescribing, but then the challenges are almost always cultural or interpersonal, and so to be able to have a group interaction immediately just seems really important. So I cut you off. You were about to say something else that's happening on, you were saying that's on the patient side, and
Yeah. And then I think figuring out, so when we're talking about racism in healthcare, and we're talking about systemic inequities, and we're finding community and finding places that are identifying it as a priority was something that was super important to me. And everything from like, and you know, there's still so much work to do, right? And I think like part of it starts with learning the history, right? Learning the pretty horrid history of gynecology in this country, learning the racism that existed within the field of midwifery and towards midwives, and exist at the national level within our own organizations to this day. So like that's a lot of the work, right? Is self-reflection and learning, and then finding community at work and joining committees and talking about it. And I think addressing it not only within healthcare, but within healthcare education. And one of the things that that I've continued to do, that I started in the Bay Area, is work with a group that provides training on structural racism to healthcare learners. So figuring out how can we start to incorporate conversations about systemic drivers of health and healthcare. I think we focus so much on disease and pathology when we learn in nursing, when we learn in public health, when we learn in medicine. There's a lot of disease, pathology, behavioral changes, healthy diet, without actually focusing on what are the upstream factors that that lead to these outcomes. And so wherever possible, pushing that conversation into our education has been another goal of mine.
you mentioned like the history of midwifery and racism. Like I'm only very distantly familiar with it, and wondering if you can like give the top line, you know, the first line of the Wikipedia article or whatever.
Yeah, does anybody else familiar with this history of racism within? So
There's a little nod from Irene.
Irene, is there anything you wanna share? Not to put you on the spot.
You know, it's just something that, you know, I recognize as something that my culture experiences. I feel like there's plenty of evidence, you know, that supports that there's unfair treatment that has existed in the past and causes these kind of this mistrust between patients and providers. You know, just being from North Carolina, I know about the history of eugenics, which is, you know, forced sterilization right here in this county. There are people who I know who had to go through that, you know, thanks to, you know, new books that have come out, like the Immortal Life of Henrietta Lacks. What happened to this female was that they took her cells without her permission. She did not have a good outcome. And medical science has profited billions on her. And there's been no restitution or or anything that for the family. So, and the Tuskegee syphilis experiment. So there, I mean, I just feel like these are always in the back of our minds. These are the stories that we grew up on, and so many families, you only go to the doctor if you're dead or dying. Is kind of like the mentality about it. Don't trust what they do to you. Don't trust what they're going to put into you. So that's just my experience and my view on things. Just feel like the unfair treatment has been systemic.
Yeah. And I think it happens like it's systemic and it's internal and it's external, right? So like when we look at a lot of like who the first midwives were that were practicing in this country, they were Black women, right? They were Black women who were not only delivering their fellow Black women's babies, but also delivering the babies of the white women in the community. And they were really looked at as these knowledge and healers, you know, these knowledge carriers and healers. And there wasn't even a specific branch of medicine that dealt with obstetrics, right? So then in the early 1900s, the American Medical Association realized that it would be profitable and it could be a power thing if they could create a branch of medicine that dealt with gynecology and reproductive health, and then became the College of Obstetrics and Gynecology, and birth largely moved into the hospital. And what was done was a smear campaign, right? It was like a very racist smear campaign against midwives, calling them dirty, calling them, you know, unfit, posting newspaper ads. There's an amazing, I went to this amazing museum in New Orleans looking at like the history of the public relations campaign that was done against these really wise community midwives. And what they did was they moved birth into the hospital, right? And like so much of birth changed. Like women started birthing on their backs because that was convenient for physicians. And so anyway, even the creation of like the male gynecologist was done with a very kind of systemic, direct attack towards midwives. And then I think like you'll learn more and more as you get into nursing and into professional organizations. Like there's so many amazing midwives that I work with and amazing nurses that I work with, but like we still live in a white supremacist society, right? Where like even our professional organizations kind of adhere to certain hierarchies of whiteness. And I think it's still a struggle to make sure that within our own organization, we're working to break down those systems.
Can I change gears a little? So your scope of practice, can you tell us some of the things that you cannot do as a nurse midwife, and then those things that you can still totally do?
Yeah, that's a really great question. So, oh my gosh, this is like a little bad. So I think in Massachusetts, I have independent practice rights, right? So I don't think I need, so every state as an advanced practice practitioner, you will have scope of like a bylaws of your scope of practice, right? So like some states have collaborative agreements where nurse midwives need to have a collaborative agreement with a physician. Some states have a supervision clause, right? Where you need to have somebody who you are signed on, who can sign on and supervise you, whatever that means. And some states have independent practice. It's really bad that I actually don't know what I think our agreement is in Massachusetts. I believe it's either collaborative or independent practice. I, as a nurse midwife in Massachusetts, I can provide full gynecology care. I can first assist in surgeries, which I don't do in my hospital just because residents do that. I can provide abortions. I can charge independently, so I can like sign admission and discharge and charge independently for my services. I cannot practice as a home birth midwife in Massachusetts. Certified nurse midwives are not allowed to practice in home birth. It's only licensed midwives, which you'll learn more and more about. Like there's like, I mean, we all sit for the same training exam, but we go through different structures of education and then are licensed by different boards. So yeah, I don't know. I have like a DEA, so I can sign off for prescribed narcotics. I can prescribe Suboxone and methadone. I don't. It's just not within my practice here. I'm trying to think what else. Is there anything that I'm missing that people want to know if I have specific right to do?
So you can deliver in your hospital, just not at home.
Yeah, I can deliver at a hospital and a birth center. I cannot, a licensed birth center. So if you want to have a home birth in Massachusetts, you find a licensed midwife who can deliver at home.
Licensed, okay.
Yeah.
And do you find more people are asking for a nurse midwife, or even just something other than a doctor or MD or DO? Like, are they gravitating towards that nowadays, or?
Yeah, I think, of course, my view is going to be a little bit biased because I'm living in a world where people accept and seek out nurse midwifery. I think it's very regional. I think more and more hospitals are realizing that when they hire midwives, that it's a benefit for them to hire midwives, right? I am cheaper to employ than my OBGYN counterpart. My malpractice insurance is less. And statistically, when you look at hospitals where midwives practice and are allowed to practice to the scope of their practice, outcomes are better, right? Improve patient satisfaction and decrease number of C-sections. So like one of the biggest and early foundations that realize this is Kaiser, right? So the Kaiser system on the West Coast, I'm not sure if you guys are familiar with it, but it is it's the largest employer of midwives in the country, and they're all about preventative care. And they're also their own health insurance company, right? So they pay for the care upfront, and then they are the reimburser. So they're really interested in improving outcomes and decreasing costs. And they have a ton of midwives. I think that, yeah, there's a very specific desire to seek midwives. And I think more and more, especially as people are learning, like, that you need to kind of advocate for agency within the healthcare system. I think midwives are seen as that. The practice where I am actually centers midwives and family practice doctors as the primary providers of care and caregivers of low risk birth. So if somebody comes in and they're pregnant, or they are in labor and they're like low risk, so meaning like not significant comorbidities or complications, their care is automatically filtered into the primary care doctors or the midwives. And then the OBGYNs they focus on their specialization, which is high risk and operative birth. So the OBs really focus on C-sections, forceps, vacuums, and really complex medical patients in my practice.
Speaking of forceps and vacuums, is that a state thing? Because apparently North Carolina midwives are not allowed to use vacuums and forceps.
Oh, interesting. Yeah, I think it's a state thing. I've never used vacuums or forceps. I think that you can in California use vacuums. Most midwives are not trained in doing so. But yeah, it's state by state. The other one that's state by state is versions. So when I was in California, I'm much more familiar with what I can and can't do in California, which is crazy just because I sat on a political board while I was there. But California was working to get their midwives access to do versions. But we can care for patients who've had C-sections in the past.
Versions are the external,
yeah.
Moving around, readjusting the baby.
Yeah,
No.
getting a baby to be head down.
We had a test question about that today.
Yeah, we all totally missed it.
Oh.
We also had a little discussion about why the intrauterine monitoring devices, like how nurses, RNs are allowed to do the electrode on the fetal scalp, the needle, but then we're not allowed to put in an intrauterine pressure catheter.
Really?
Yeah.
We don't know why, but apparently that's how it is.
And are nurses allowed to do cervical exams prior?
Yes. Well, we just thought it's a lot more harm, risk putting a needle into a baby's scalp than like just pushing a catheter into the uterine space. But
Yeah.
Apparently not.
No, I pause a lot. It's a lot scarier to put an FSE on than it is the catheter.
Prior to school for nurse midwifery, did you have to have some labor and delivery experience, or was it not required?
It was not required. So the school in Philly where I went to my nursing career, they really encourage people who were going. So my plan was to do the midwifery program in Philly. And they really encourage people to stop and get nursing experience. They thought that it was easier to place them in they found that it was easier to place them in clinical placements when they were doing the midwifery program. Like, people were more receptive to somebody who'd worked in a hospital, who'd had nursing experience. When I went to school in California, there were like maybe 14 people in my class, and I was about one of three or four who'd had prior nursing experience. And, you know, everybody has to do what works for them, right? There's so many different ways to become a nurse. There's so many different ways to become a midwife. But I felt like when I went through midwifery program, I'd already had like a big part of it figured out, which is like how to be comfortable in an intimate space with people in the hospital. And I think that there was a major benefit. I think I struggled a little bit less in midwifery school than some of my peers because I'd already had that nursing experience. But
How long is midwifery school?
yeah, so it depends. Different programs are different lengths. Mine was 2 full years, but it was a little bit less compact, right? So like to the point that like I was able to work as a nurse once a week throughout my midwifery school. Other programs are a year to 18 months. The program in California was one of the longer at 2, and that's after you get the nursing degree.
Is
May I
the
ask-
schooling the same? Sorry, go ahead.
Sorry, it's quick. What may I ask? What school you went to?
Yeah, I went to UPenn, to University of Pennsylvania in Philadelphia, and then I went to UCSF in California.
Is this, so you were talking about the licensed midwife? I didn't even realize there were 2 separate ones. Is that every state? Is that like a state law or federal law about the home birth thing?
Yeah, there's actually many different types of midwives, right? There's many different licensing boards for midwives. So CPM, certified practical midwife, licensed midwife, and certified nurse midwives are the most common. Every state is different as to who can practice within that state. Certified nurse midwives, meaning you get a nursing degree and then a master's in midwifery, can practice in hospitals in all 50 states and territories. Like, they are the ones who can practice across the board in the United States.
Oh, okay.
Licensed midwives in most states, I think I don't want to speak incorrectly, but I think in most states, it's only certified nurse midwives who can practice in hospitals. Other midwives can practice in other settings, right? So meaning in freestanding birth centers, in home birth practices, and yeah, in community health centers. But every state is different. Every state is different in terms of who is licensed, what your regulations and your scope of practice are. I know that in lots of states, it's actually, so like I'm licensed by the nursing board. In many states, certified practical midwives are actually licensed by the medical board, interestingly enough.
Okay, so they go, like the licensed midwives, the ones that do home births, they go through like medical school, or are they still nurses?
No, they go through, they're not usually typically nurses first. They go through training programs. So like there's a really big, there's a few like really popular midwifery schools throughout the country that train licensed midwives. And so it's just a different education tract. You know, we all end up having to sit for the same exam. And so we all have very similar skills. And then it's state by state. So like and again, my reference point is a lot of California, but like in California, as a certified nurse midwife, I could practice in the home setting, I could practice in the birth center, or I could practice in the hospital. In Massachusetts, I'm a little bit more limited in terms of a birth center or a hospital setting.
Okay, so did you just go the certified nurse midwife track because it's what's consistent like across every state, like you can practice in every state?
Yeah, I think I went because it was what I was exposed to and what I knew the
Yeah.
most about. And yeah, I think for me it was the right decision because it is so versatile. And I think, you know, I went into midwifery knowing that I wanted to go into education and practice in a hospital. I
Mhm.
wanted to like specifically, very targetedly, like train physicians how to be more sane physicians, like how to be more better providers. And I was like, all right, I got to be the one who can practice in the hospital and teach residents, and make change somewhere. But there's so many different avenues, and I mean, that's the amazing thing about nursing and about healthcare is like, there's so many things you can do with a nursing degree when you're done with all this.
Mhm. Okay, thanks.
So I had a question. So what role do the board, what do you call them, the unions play in the requirements for education as well as, licensing?
Yeah, that's, you mean in terms of requirements for nursing education?
Yes.
I'm not sure how much the unions play what role they play. I will say that different levels of hospitals, have you guys learned about like magnet hospitals versus, yeah, so like different hospitals will have certain requirements for nurses, where they prioritize continuing education and they create like nurse residency programs. I'm not specifically sure what the unions have in that, except for maybe advocating that nurses have access to continued education and time for doing so.
I know Kaylin was, I don't know if she's with us. She's making a garden right now. I know Kaylin was wondering like about becoming a L&D nurse. Like it's one of the more hard to get nursing spots. And I'm wondering if you have any insight into what that process was like.
Yeah, I think so labor and delivery yeah, she says thanks. Labor and delivery can be a more difficult job to get like into as a new nurse. I think a lot of hospitals have a practice of hiring nurses onto medical surgical floors, onto med surg floors first, and then training you to transfer. That being said, there's lots of opportunities to become labor and delivery nurses straight from, or postpartum nurses straight from graduation. I would say keep an eye. One thing I did that was really helpful was I applied to a hospital. I specifically looked at hospitals that had new nurse residency programs. More and more hospitals are having this, where they'll have a cohort of new graduates who get some nurse residency. It's a nurse residency training program. So you get like professional issues classes and like extra support in terms of transitioning into the nursing role. And a lot of those places will specifically have a new nurse, like a new labor and delivery cohort, or a new mother baby, meaning postpartum cohort. The other thing is your clinical placements. Like I kind of fought this when I was in nursing school. I was like, I'm going to apply to these jobs all over the place. And then I ended up getting a job where one of my clinical placements was. I think so, just as much as possible, either like talking to people at your clinical placements, and even if it's not like the place where you do your labor and delivery shifts, but you do med surg shifts, be like, you know, don't be afraid to talk to the nurse manager and be like, hey, can I talk to your nurse manager in labor and delivery? And that exposure to where you get to do your hands-on training is a big coup in for getting nursing jobs. So it's not impossible.
Well, I just want to say thanks, big thanks. Does anybody have other questions or anything? Yeah, I just really appreciate. Yeah.
I saw one question. Me and we talked about it briefly in class about.
Oh yeah.
Yeah, like males in this field of midwifery. Have you had any experiences, positives, negatives, or and also the I guess the preferences from the patients?
Yeah, it's a great question. And yes, I have had experience. I think that I know a few, right? Like not a ton, but I know a few really, really wonderful male midwives. And I think when you think of like who it is that we're providing care to, like there are some patients who are going to feel, you know, more comfortable with a female provider. There's going to be patients who feel more comfortable with a male provider, and there's going to be patients who kind of don't have a specific preference one way or the other. I think that as more and more, specifically, I think of like individuals who don't identify as female and who are birthing, there's a certain, you know, that might be an area where there's a certain comfort for male providers, or, you know, I think that there's male midwives out there. I think that there's a need for more male midwives out there, because I just think that diversity in options of care providers is the only way that we're going to get to safe, equitable care for everybody. So I say, if you're interested in it, Isaiah, go for it. And some of the best mentors I've had have been male midwives. It's interesting because there's so many OBGYN providers who are male, right? There's so many OB doctors who are male, and less of a volume of midwives. But I think when people think midwife, they think there's a very gendered assumption about some of the attributes and some of the roles that you fill. And I think we need more men and people of all genders to occupy that and kind of change that definition.
I think they also need to change the name because it has the word wife in it. So
yeah, and midwife actually means with women, and which is beautiful, but also I do more than just provide support to women. So yeah, I'm all about figuring out, and you know, our language should always be evolving. And I think that if I'm not feeling behind on my language at some corner or the other, then I'm not keeping up with the world, you know.
Well, I remembered one other thing. Are there any, like, can you give us a dose of like what your, like, have you had birthing experiences in the last week? Like, have you had babies come out in the last week? Like what's your life like? What are you witnessing? Without any HIPAA violations.
Yeah, without any HIPAA violations. Yeah, I was with a woman when she had a baby on Sunday.
So 2 days ago.
2 days ago. I wasn't supposed to be working, actually. It was my Sunday off, and took the dog for a walk, was having a slow Sunday, and then got a phone call that my coworker who was working had to leave emergently. Her mom was sick. And so I went in. I was kind of a little bit bummed about it, but I was like, it's okay. People would do this for me. And I went in, and it was a really nice, slow Sunday. And then I admitted somebody who somebody was just being admitted to the labor floor when I'd gotten there. It was her fourth baby. And she wasn't contracting a lot. She was having contractions like maybe once every 30 minutes, which I don't know if you learned this in your test yet, but like active labor, we think of like closer to like every 3 to 4 minutes for an hour or two. But it was her fourth baby, and her second baby had died at 3 days of life. And so she was, I think both she and her care, and she had 2 daughters and a son that had died at 3 days of life many years, several years ago. And this was another son. So it was her first son since then. And I think that she and her midwife were both a little bit on the more nervous side about the whole pregnancy because of that. And so even though she was only 4 centimeters dilated, and we really don't typically admit people until they're kind of more active, either 5 or 6, or they're contracting more frequently, she stayed with us early. And she got a little bit of Pitocin, right? Because her contractions were very, very infrequent. So she got a little bit of Pitocin to augment her labor. And within about 2 hours, an hour and a half of starting her Pitocin, she was pushing. And I felt like I was just the spectator in this event. You know, she didn't need me there. This was her 4th time having a baby. She just needed somebody to like clean up when she was done. And that's kind of what we did. And it's amazing in my job. I thought that I would get jealous or envious or protective of birth when I work with learners, right? So I work with a lot of residents. So when I'm in a birth, there's somebody who's with me and who's learning in the process. But I love watching that journey, right? Like half the time I'm midwifing the resident and not midwifing the patient. I'm like providing emotional support for the learner as they're going through the process. And somebody's having their 4th baby. Like my only job is to slow the head down so that it doesn't come out too fast. And the resident was a very new resident. And I was like, at one point I turned to her, I was like, you need to have gloves on right now. She's like, oh, do you think so? And she missed the head delivering. It's okay. She was there to get the rest of the body out. And the woman just did amazing. And you could tell that she was relieved, right? As soon as she like held this live baby in her arms, she was just super, super relieved. And
did she have support in the room?
Yeah, she had her partner. She had her husband with her.
Is it limited to one person with COVID or? Yeah.
It's limited to one person.
Was it always limited?
No, it was 3.
Okay.
It's limited to one person and a doula. A doula, even whether we have hospital doulas that are employed by the hospital, and they can be in the birth, or an outside of hospital doula is considered a healthcare employee. And yeah, it was amazing. She just like smiled like, the entire time. She had no tears. She lost a very little amount of blood. And she just did great. She did great.
I know that L&D nurses and midwives tend to keep track of the number of babies. Do you do that?
It's so bad. Like electronic healthcare records can help so much. So I haven't. Before I took this job, I had 62 births. 62. And last time I checked, I'd had like over 300 since I started. So I don't know. I could run an algorithm. This is probably an inspiration to do so, but I should run an Epic algorithm to see how many births I've been in. I will say that my first year at BMC, I caught more babies than any other midwife in the practice, which was just because I was working so much on the labor floor when I started. So yeah, I have no idea. Some people are so good. People find these things, right, that are important to you in healthcare. Cause I love this. Like I have peers who will write a one-liner about every birth that they're in still. And I haven't.
Well, we're going to send you a gift. It's a little sticker that says, you see a peace sign, I see 5 to 6 centimeters. It's inspired by one of our teachers.
I love that. Thank you. Have you guys gotten into the habit of measuring everything in your house?
Ooh, that's fun.
Yeah, like what can I do? Like here's a tight 3.
Ooh.
About 7. Yeah. Exactly. That looks like, I don't know, that looks like 3.5, maybe 4. Yeah. These 2 fingers.
It's like latent stage to me.
Looks like, yeah, latent stage, right? You realize that like these 2 fingers are like probably the most valuable thing on my body next to my brain. And so like, I'm a little bit obsessive of taking care of my hands, but it comes with the work. Well, thank you guys. I'm so excited for all of you. I think like nursing, you're like in it. You're in the like actualization of this journey, and nurses are some of the best people I know, right? There's so much you can do with this degree when you're done, from like policy to bedside to education to whatever you want to. I think nurses are our future. So Thanks so much.
Thank you.
Thank you so much. It was really helpful.
Thank
Mhm.
you.
Thank you. This was exciting.
And Will, you can feel free to share my email if people have follow-up questions.
Yes, yes. I replied. I reminded most of y'all. Sarah, I don't think I sent you one, but you should have Kara's email CC'd on that email. Yeah.
Okay, yeah, I got that email. Thanks.
Oh, sweet. Yes, yes, yes. Perfect. All right. Okay. See you soon. See you later.
Thank you so much, Cara.
Cool.
Super.